Hello, welcome to the Navigating Sexual Wellness with ICBPS webinar. Today's session features Dr. Rachel Rubin and Heather Florio, the Chief Executive Officer of Desert Harvest. Thank you to Desert Harvest for sponsoring our IC Awareness month-long event, including tonight's webinar. We are so excited that you're here with us today. Before we start, I have a few housekeeping items. First, please note that this session will be recorded. And second, we will have a Q&A session following the presentation. If you want to ask a general medical question, please note no personal questions tonight. Please use the Q&A feature. Our presenters will answer as many questions as they can in our hour-long webinar. And finally, please complete the post-webinar survey. A link to the survey will be posted in the chat at the end of the presentation. It's time to get started, so without further ado, please welcome Heather Florio, CEO of Desert Harvest.
Thank you, Lee. I appreciate it for having us here today. I would like the pleasure here of introducing Dr. Rachel Rubin. For those who do not know, she is a board-certified urologist and sexual health expert, and she is here today to talk about the intersection between bladder pain, interstitial cystitis, and sexual health. Dr. Rubin, thank you for joining us today.
Oh my gosh, I'm just so thrilled to be here. It's one of those marathon days where you're doing so much, and then this just energizes me like nothing else. So I'm going to have trouble falling asleep after this. And thank you all for coming so late at night to do this. On the East Coast, I should say.
On the East Coast, yeah. I mean, who needs sleep, right? So why don't we start by talking about sexual medicine? What is it? Can you kind of give us a definition, a little background?
Yeah, so I'm a urologist, and so obviously urologists take care of all genders and deal with bladders and kidneys and prostates and things like that. But we also do sexual medicine. We take care of a lot of men's sexual health, and then there's a handful of us that take care of everybody's sexual health. And so I did a special fellowship that really learned a lot about sexual health for everybody. And as a sexual medicine doctor, I do 4 things. I deal with issues of libido, arousal, orgasm, and pain. And that pain one is a big old bucket that crosses over into all the other buckets. And so I do a lot of pelvic pain, which can, of course, include bladder pain. And I try to look at it from the lens of quality of life and how can we maximize everybody's quality of life.
So how do you kind of, we talk about pain here, one of the predominant symptoms of interstitial cystitis, bladder pain syndrome. How do you kind of approach bladder pain in your clinic?
Yeah, so it's a great question. And I think for me, it's really important to take a lot of time with people. I'm not like doctors who pack 50 patients in clinic a day. I can't do that. It would kill me, like literally kill me, because I really want to get to know the patient in front of me. And for me, that takes an hour virtual or an hour and a half in person if I'm going to do an exam. And even that, I'm like, it's not enough time. I need more time. I want to really get into the weeds about your life, about who you are, about what you care about. How can I help treat your pain and your quality of life if I don't understand it? How can any medical provider understand your 30-year pelvic pain history in a 10-minute visit? Are you kidding me? There's no way. There's no way. And so I approach it very differently. I really, really want to get a good history. I mean, and really work with the person in front of me to get that good history. I feel like I'm a little bit, I call myself like a sex detective. Like I want to kind of ask questions to really try to understand where are the issues. I ask questions that probably nobody has ever asked you before. And the more I learn, the more questions I start asking people, the more sort of we start seeing connections and we start seeing themes and things like that. So that's a long-winded way of saying the way I approach all sexual health issues, including bladder pain patients, is in a new sort of paradigm by what we call region-based therapy, meaning I really think about where is all this coming from? What's going on in your brain? what's going on in your spinal cord and what's going on in the pelvis itself. Where is the problem? And you may have multiple problems, but we have to understand, are the problems tissue, muscle, nerve, and really think through how do the psychosocial traumas affect your pain? Although I don't start with psychosocial trauma, though, of course, we take a biopsychosocial approach and really try to understand it. And so I think the main thing that I like to get across to my bladder pain community is y'all don't have the same thing, right? If you take a room full of people with back pain, they all don't have the same thing. Some of them have bulging discs, some have annular tears, some have Tarlov cysts, some have, back muscle issues. And so we have to understand as a community that so many of you are very different. And unless we fully understand you as an individual, it's really hard to get that social media advice. It's really hard to take that Instagram reel and say, well, how does that apply to me? And so that being in that exam room is very, very important.
Oh, yeah. So we go a little bit into that. How about hormones? Menopause. How does this play a role in all of this?
Absolutely. And so hormones are so, if y'all follow me on social media, which you should all follow me on social media, I talk a lot about menopause. I talk a lot about hormones, and we talk about hormones even before menopause, because there are certain things that can put your body and your bladder in a menopausal state, even when you're not in menopause. And then sometimes if you have bladder pain and then you go into menopause, it's adding a fuel to the fire and worsening the bladder pain. And so sometimes people with chronic illnesses forget that they're also just regular people who go through menopause and things like that. And they forget about doing their colonoscopy or their mammogram because they're so focused on the pain. And so hormones really matter for the bladder, really matter. They matter for the bladder, the urethra, the vulva, and the very important tissue, which is called the vulvar vestibule, which is the tissue at the opening of the vulva that surrounds the urethra that is often a source of pain for my bladder pain patients. And that tissue is very hormone sensitive. The bladder, the vulvar vestibule, the pelvic floor, they're very hormone sensitive. And when you play with hormones, there are consequences. Sometimes good, sometimes bad, but sometimes there are consequences. So if you're breastfeeding, right, your hormones dip to nothing. So you can get dryness, you can get pain, you can get urinary frequency, urgency, you can even develop IC symptoms, but it's due to a pelvic floor tightening and a lack of hormones to the tissue because of the breastfeeding. And so the hormones are really important, and there are different things like birth control pills and breast cancer therapies, and even disordered eating. People with eating disorders have low hormone states that we can see some pelvic pain problems pop up. So hormones are extremely important to talk about. And y'all, I know you go see urologists. I teach the urologists because they don't know anything about this. And that's what's so frustrating, is that the doctor in front of you doesn't always know everything, which is so horrifically aggravating for you as the patient.
I'm going to throw a question in here that's come in through the Q&A because I think this is a good time. This one is, I was on Danazol for years. I'm 64 and doctors don't know what to give me for hormones because I didn't start early enough. Do you recommend estrogen for people with IC, lichen sclerosis, etc.?
Yeah, so it's a great question, and thank you for sharing that. So local hormones for the bladder, for the urethra, for the vulva, whether it is a vaginal estrogen or even better, a vaginal DHEA product, is safe for everybody to take. So it is safe for you to take at 64. It's safe for, if I had a great grandmother who was 98, it would be safe for her to take, right? So it is so safe for breast cancer patients, for every kind of cancer patients, for people with a history of blood clots, stroke, heart disease, family histories of cancer. Local vaginal hormones are safe for everybody. Okay, because what they do is they prevent urinary tract infections. They fix frequency and urgency. They fix pain with sex. They are the foundation. And so if you are a bladder pain patient, right, who is not on vaginal hormone therapy, even in premenopause, I'll be honest, You're missing a foundational support system that will really help you. Now, I'm not saying it's the only thing and it's the magic cure that you've been looking for, but it is a foundational element that the tissue needs to be hormonally healthy and strong. A, so it can be acidic and fight infection. B, so that the pelvic floor muscles aren't attacked and they can learn how to relax, often with help of a physical therapist, right? And so so it's really important to understand how local vaginal hormones, which are safe for everybody, right, can help with the bladder pain symptoms. And I hope that's clear. I do a lot of speaking about this on social media, webinars, YouTube videos, because you got to hear it over and over and over again by different people in different ways. And then your brain clicks and you're like, oh my God, my great aunt, she needs vaginal hormones because she's had a urinary tract infection, is in the hospital on IV antibiotics, which can kill her, right? Urinary tract infections can kill you. This is not a little vaginal dryness, people, right? We minimize things like vaginal dryness where we say, oh, it's fine, just use some lubricant. Lube's great. We love it, right? Sure, like we have no problem with it. But we have to fix the problem, fix the microbiome. And the thing that does that the best are vaginal hormones, which are often covered by your insurance, which are not very expensive. You can get a tube of vaginal estrogen for $20. So it's accessible for people.
Perfect. I'm going to throw in another one here. Do you recommend, so a lot of people that come to Desert Harvest, at least, there are many that experience breast cancer and have been recommended by their clinician maybe not to do more hormones, but but they're experiencing the symptoms, they're experiencing vulvodynia, they're experiencing a hypertonic pelvic floor. Would you have any recommendations for those patients that maybe are being recommended not to utilize hormones?
Yeah, so there are non-hormonal therapies that can be quite helpful as Band-Aids. But when you are suffering deeply from bladder pain, from pelvic pain, and everyone on this call, nobody shows up to a webinar, 50 people don't show up to a webinar at 8:30 at night, about bladder pain unless they are suffering, right? Everyone who is on this call is suffering and is miserable. And when you can't wear pants and you can't wipe yourself and you can't sit and you can't sleep through the night and you are not living your life, well, then your doctors and you need to have real conversations about risk and benefits. There is no data on earth that shows a home run connection between local vaginal hormones and breast cancer. And so in this fear of what could be possible, but has never been proven with science, people are suffering. People are suffering deeply. And so think of something like tamoxifen. Tamoxifen is a treatment that people take for breast cancer to prevent recurrence. And it's a small percentage that can prevent recurrence. It can cause uterine cancer. It's on the box. And we tell you, hey, you're going to take this thing. It's going to help prevent breast cancer recurrence. It may cause uterine cancer. We'll deal with it if it shows up. And yet people take it and deal with the horrific side effects from it because of right? So we make decisions, the benefits, the risk. And so the problem is really, Heather, the problem is that we talk about these symptoms as though it's just a little vaginal dryness. Oh, suck it up. You have a little frequency and urgency. Oh, it's fine. Just use a moisturizer. You'll be okay. My friends, 52 people do not show up at a webinar this late at night for a little vaginal dryness. This is horrific, life-changing pain that affects intimacy, sexual health, quality of life, driving to go on vacation, hugging your grandchildren, like making it through the Barbie movie, right? This affects so much. Don't miss the Barbie movie, by the way. It's worth. I just saw it. I was late to the party and it was worth it.
It's on streaming now. Just saying.
Get out of here. Oh man,
yeah,
I could have watched it on my couch.
Yeah.
I hadn't been to a movie theater in, I think, 10 years or more. It's really wild.
Oh, I that's a lot more than I was expecting. I was expecting you to say the pandemic.
No, it was very, very pre-pandemic. I fall asleep at movies, so it's never worth the money.
So how can you, you talk about, the misinformation that's happening here in the communities, might even be coming from a clinician. How can you best advocate for yourself?
It's really challenging, and I don't have all the answers, y'all. I do not. I wish I did. I wish I did, because the modern medical system is broken at every single level. I want you to understand this. I know a journalist. I'm going to tell you a story. I know, and I have some questions that are going on in the chat that I do want to address, because the hormone piece, not all hormones are the same thing. Birth control is not the same as local vaginal hormones, and we could talk about it and get into the weeds. But I want to tell you a quick story. I have a friend who's a journalist in New York City, and we know each other from social media. I've never met her. Okay. And she wrote an article about having urinary tract infections, and she wrote an article for the Atlantic. And I sent her a private message on Twitter, and I said, "You're not getting the right treatment. You need vaginal hormones." And so she ended up ultimately going to doctors, and she was having recurrent urinary tract infections. And she thinks of me that I saved her life because I just tweeted at her that she was being mismanaged and she wasn't getting good help. Now, she texted me this week or last week, and she said, "I have another UTI, and I've messaged the local urologist who you're friends with, who you sent me to, and no one's writing me back. No one's answering the portal messages. I've been freaking miserable for 4 days. What in the fresh hell? Don't tell people to go to this doctor." And I said, wait a minute. I said, this doctor doesn't get a medical assistant, doesn't have help in her clinic. She's at a busy university where she has no resources, and she's about to leave medicine because she just went on vacation for a week, and she came back to 7,000 messages in the portal. Doctors are committing suicide. Doctors are having to deal with insurance companies that won't let them get the prescriptions that they want them to get. Doctors are getting reimbursed $24 for your 10-minute visit, which is why they do a 10-minute visit. And so every level, it is broken, and patients are suffering deeply, right? And so this journalist who's a health writer was like, oh, I didn't realize, right? She's thinking her doctor is evil, right? When she didn't realize how terrible the system truly is. And so it's a big, I forget now what the question was, but it's a really big challenge to know how to know that you're getting good medical care. And so what I believe, and don't tell too many people this, because I think if the word gets out, I think there might be rioting. But I believe if you give people enough knowledge about how their bodies work, they can make excellent decisions about their healthcare, like excellent decisions, right? When I talk to people and I say, okay, this is what you could do here, and it could be the muscle, and it could be this, and we could try this, this, and this, people say to me, oh, that makes sense, and that's where my pain is, and this is what's going on. Okay, I've heard what you had to say, Dr. Rubin. I think if we go here, then here. I really don't want to do that thing, though, because it doesn't sound right for me. Great. Let's do it. And they're almost always right. Like when you listen to people and they tell, like, that's why I think the history is so magical, because people often, their stories give away kind of what's going on with them, and it's really, but if we don't take the time to listen to the story, and that no one's paying attention, and unfortunately with the medical system the way that it is, you often have to be the person advocating on your own behalf, which is so unfair and so challenging. But some of you just do it like really well, like you're really amazing at it. And then hopefully you're friends with the people who are good at it too, because they can help support you.
Yeah, like at Desert Harvest, our customer service team, they will stay on the phone for hours if they need to. We're there to be a voice, and many of ours are suicide trained because we deal with that so often and have to get and connect different people. So it's finding your network and your voice. And so let's jump into some of these questions. I know
and we can talk about male IC too. I see there's some wonderful men in the audience, which is so good. I treat men as well. They don't have there is some probably hormonal connection with testosterone, but we don't see as much the obvious foundational effects. So for men, we look at pelvic floor, we look at spine issues, we look at prostate issues. Obviously, there's a lot of other things. We're still looking at the same things. There's just some subtleties for sure.
So do we want to jump into maybe some of as we kind of talk about the vaginal hormones, and then we can go into the men. Do you want to talk about so I'm going to bring these up because a lot of these overlap. So we've got one gal here that's asking, is vaginal hormone therapy only estradiol cream? What do you recommend for vaginal hormones, vaginal estrogen? What is the typical dose and frequency for bladder health? All very similar questions.
Yeah, so there's a number of different therapies that we have for vaginal hormones. We can use either estrogen. So for FDA approved products, we have estradiol, and we have DHEA. We love DHEA because it is the tissue at the vestibule, the urethra, the bladder needs some testosterone, needs some androgens too. It's a story that isn't talked about loudly enough in the IC communities, but should be. But there is a lot of a testosterone story that is not told about interstitial cystitis. And so low testosterone states can really worsen that tissue at the vulvar vestibule and the urethra. And so birth control pills cause a low testosterone state. So for the person who says birth control made my IC worse, of course it did, because what it did was it lowered your testosterone levels, which deprived the urethra and the vulvar vestibule and the bladder of the hormones that it wanted so badly. So when you use a vaginal estrogen or a DHEA, you're giving your body back the hormones that it really wants. And sometimes estrogen is not enough. Sometimes you need that androgen or that testosterone base. So we'll use vaginal DHEA, which shows a lot of promise in pelvic pain and UTI prevention. We may use a vaginal estrogen product, which looks like either an insert twice a week or a cream that can go in twice a week as well. Sometimes there is a ring that is very unaffordable for many people and poorly covered by insurance that can stay in for 3 months at a time. And so a lot of times the doctors underdose it, where they say, oh, just put a little dab of the cream on, and it's not enough to fix the problem. You got to really, do a gram of the cream or do the insert. The DHEA is a suppository that you put in nightly that is very a lovely product. And so it can look a lot of different ways. Local vaginal hormones are different than birth control pills. It's different than a hormone therapy for a patch or something for hot flashes. And often if you're on something for hot flashes, you still need the local therapy at the tissue level. Many patients with bladder pain, can I give you guys a secret? Just get you in the insights into a urologist's brain. I know my colleagues pretty well. When you come in and say you have bladder urgency, I want you all, I can't see any of you, but I want you all to point to where your urgency and your pain are. Now, my prediction is that 80% of you are pointing in between your legs at your vulvas, and your doctors are assuming that 80% of you are pointing above your pubic bone inside your bladder. And so it's right. So I don't even think we're having the same conversations as we think we are with our doctors, because we are saying urgency, and in our brains, it's our vulvas. It's like the urethra. It's like happening there. But our doctors' brains are thinking it's suprapubic above the bladder. And some of you do have suprapubic pain there, but many of you don't. Many of you have urethral pain, which is actually usually vulvar vestibule pain, which is very sensitive to hormones. And so things like birth control, breastfeeding, breast cancer treatments, and menopause can really hurt this tissue and increase that interstitial cystitis pain. Does that make sense, Heather?
Oh, yes, that makes sense 100%.
And y'all, I'm sorry I talk so fast. It's just that
you're trying to communicate a lot of information in a short period of time.
I've been in this rodeo before.
I think that this one, maybe we should go a little further down the intercourse path. Do you recommend a sexual position that makes sexual pain less painful?
Yeah. So just like y'all have different things when it comes to bladder pain, and so it's really hard to talk to your friends about it because y'all have different things. And what works for your friend may not be what works for you, which is so freaking frustrating, right? When they found this amazing thing. Sex is not the same for everybody. Pleasure, joy, intimacy, the things that feel good, the things that are important, it's very different for all of you. And that's why I really do take time to figure out from my patients, I'll ask them, what does sex look like right now? And what's your dream? What do you want it to look like? What are the goals? What kind of sex do you want to have? What is it, how do you experience pleasure? And is there any pleasure at all? Because if it's only pain, it's not going to be very fun, right? Remember, y'all, sex is supposed to be fun. And if you're not having fun, or only one person, if you are having sex with a person and only one person is having fun, it's not fun, right? Like no one likes to have fun by themselves if they're in a group. And so you got to really figure out your own manual, because I'll tell you, in sex ed in middle school, you didn't get that lesson of like, what positions help when you have IC and bladder pain and your partner's really interested, and like that's like not a thing. Y'all didn't come with a manual. And so you have to rewrite the manual or write it at all from scratch. And so sometimes it's learning and exploring and using devices. We love devices and things that vibrate, things that feel good on the outside. You may not need penetration. It's also just touch, right? For some people, it's touch outside of the area of the pelvis. For some people, it's a massage. For some people, it's a warm bath. Remember, sex is not, nobody ever died because they didn't have an orgasm. It's true. You got to tell some people do think that sometimes, but you have to understand the purpose of all of it. The purpose is for love and intimacy, connection, orgasm in some instances, right? All of these things. So how can you achieve the goals of sexuality? Now, if you're trying to make a baby, that's a whole other story. And there are ways to make a baby without penetration. People have been doing it for a very long time. And so I hope that helps. So there is no one right position because everyone's bodies are shaped differently. And depending on where your pain is it penetration pain right at the opening? Is it deeper pain? Is it pain where you really feel urgency all the time? Well, our treatment strategies are going to differ. And we love working with sex therapists. Everybody gets better. You know, everyone does well with sex therapists because it helps us communicate about it, right? If we can't communicate about it, you know, y'all, we had like 20 emails go back and forth about this very webinar. What are you going to talk about? What are we going to say? How are we going to get people, right? Nobody does that much to plan sex or to talk about sex or to say what went well, what didn't go well, what can we do better next time? Why? Right? We're not putting as much effort in our sexual health as we do a webinar. That doesn't make any sense.
Exactly. Yeah, we recently did a webinar that was with a place called Authentic Tantra, and they are actually the only Tantra certified by a government agency, which is actually in Canada. And it was so insightful to be able to learn about different ways in which we can experience pleasure without any type of penetration. It was wonderful.
I love it.
Yeah. And then let's jump in to maybe this next question. I think this leads in when we talk about penetration. I'll chime in if you don't mind here just a little bit,
Please.
Dr. Rubin, because we actually, Desert Harvest has a 4% lidocaine product, and it's very interesting. And I'd be really interested to hear your thoughts on this because we know that as a lubricant, a lidocaine gel, one participant here is asking, I use lidocaine gel as a lubricant for intercourse. Is that appropriate? And for us, like our lidocaine product, we typically have them use it at the vestibule and then utilize a more standard lubricant like our Desert Harvest isoosmolar pH balanced Alloglide as a sexual lubricant to kind of get past that painful barrier of maybe either dilate or work for penetration or anything like that. What are your thoughts on that?
Yeah, I think it's excellent advice. And I think that it's really important that you know, one of my favorite things to explain to doctors when they're examining people for bladder pain or vulvar pain conditions is where the person doesn't have pain is actually just as important where they do have pain, right? And so you have to really understand where your pain is located. So most people don't have pain in their skin. So their labia majora and their labia minora, for most people, do not hurt to the touch. Not everybody, right? It is really when you open and spread the labia that the inside of the labia, which is that vulvar vestibule. And again, I know there are male IC patients here, and I apologize for a moment, but it is that tissue that is burning, raw, and irritated. And for many people, it's actually not inside the vagina that tends to hurt them. So to your point, if you can numb that vestibule, can penetration be more comfortable? Now, people who have very tight, tender pelvic floors, so think of tight muscles, really tight muscles, that can kind of feel, it's usually a burning muscle pain as opposed to like a fiery raw cutting, like, pain at the opening. And so when you understand your pain and what is hurting, then you can understand what might be helpful for you. But just, slathering everything in lidocaine, well, too high of a dose of lidocaine probably isn't too good for you. And also you can numb your partner potentially, which may be helpful for them, but not always. And it may not be necessary, right, to go to do all of that. And so you really have to understand your own sort of pain points there.
And you mentioned men. So for men, lidocaine, right, is going to make them more go longer. It doesn't necessarily desensitize, but more extends their reach to orgasm, correct?
Yeah. We use a lot of lidocaine sprays and gels and things like that for our premature ejaculation patients who would like to go longer. And so it can be helpful for, I always joke, one person's sexual cure is another person's like sexual nightmare. So right, like if you lidocaine can burn some people, right? When it goes on, it can irritate tissue, which is why, your formulations, I know you're trying to really help the tissue. It can really hurt. And so you really want to do something, you put it on, you're numb, you have intimacy, whatever that looks like for you, then it wears off and you're usually pretty damn sore after, right? So these Band-Aids are often necessary and we love Band-Aids, but as your physician, I really want to get to the underlying cause and really try to heal the tissue. And if it's a hormonal cause, then we give back hormones. So there's a lot of questions about Botox. If it's a muscle cause, then putting botulinum toxin into the muscles can be life-changing. If it's a spine pathology that is aggressively, someone asked in the chat box, they said, why some days it hurts so bad and other days it feels fine? The way I think about it is those patients, to me, and I may be wrong, I think it is so much like back pain. Right? There are people who have sciatica where their leg is killing them because they picked up a newspaper and then they throw their back out, right? And then other days it's totally fine. And so for those patients, I'm often thinking about a spine pathology that's affecting their bladders because the nerves from your back innervate your bladder. And so for my patients with bladder pain, they go in a pool and they feel great. I'm thinking spine, because when you don't have the weight on your spine, things feel better. So we have to remember not everything is Hunter's ulcers. Not everything is a gag layer of the tissue. Some things are, but some people have a problem with the nerve innervation. That's why InterStim works for some people. And so Botox can be helpful for some people, either directly into the bladder or in many cases directly into the pelvic floor. And so really understanding where the pain is and where it is not can really help guide treatment strategies. And the thing is, you got to remember also these muscles are enormous. And so one round of Botox or botulinum toxin may not be enough, and you got to target it in the right places. And so sometimes it takes a couple tries. And so it can get expensive because insurance companies, here's the problem. Insurance companies won't cover Botox in the pelvic floor because many studies show that it doesn't work. Many studies show it doesn't work because they use too low of a dose in too many muscle groups. So it doesn't work because they're underdosing it and they're not doing it correctly because the stuff is so expensive. So we're stuck.
Yeah. Now, we have one a unique question here. So there have been cases of partners' genitals becoming sore and bleeding after intimacy with someone with IC.
I mean, I can't speak to I can't speak to individual stories or folklore out there, but here's the thing: if the tissue is red and raw and irritated and dry and uncomfortable, then there's lots of things that can happen to partners' anatomy and things like that. And so I can't speak to what happened in that situation, but I'm not sure what to make of that one.
Yeah, I think we have a few here. So we have lichen sclerosis, labia minora is gone. We have severe clitoral pain. Trying to see the other questions that we have here, definitely. And then we have the connection between, now this is a comorbidity of many interstitial cystitis patients, is vulvodynia. Have you ever through your practice found a correlation between interstitial cystitis and vulvodynia?
Oh, no question. I think most interstitial cystitis. So vulvodynia, and interstitial cystitis are not my favorite terms. And I know y'all have the Interstitial Cystitis Association. I'm not here to tell you. It's just, again, to me, it's like back pain, right? There's lots of different reasons for back pain. So for me, I see as sort of this pelvic pain, bladder pain thing. And so many of you have problems in that vulvar vestibule, which is a subtype of vulvodynia, because all vulvodynia means pain, and vulva means out, not the vagina. So all vulvodynia means is it hurts in my vulva. Well, okay. And in your vulva is the clitoris, the labia majora, the labia minora, the vulvar vestibule. There are muscles, there's bones, like there's lots of things in the vulva. So some of you have one thing, some of you have another thing. And so we see a ton. In fact, we did a research project when I was a fellow, and I presented it, but I got busy and had a baby and I never published it. But it was really amazing that we asked people who were treated for their vestibule problems about their interstitial cystitis diagnosis. And 80 to 90% of improvement was found in their IC symptoms when you treated the vestibule, right? And so that's really important. So if you have a hormone problem in the vestibule, you got to treat it. If you have a pelvic floor problem, you got to treat it. If you need surgical removal of your vestibule, which is rare, but can happen, you got to treat it. And that can really help with the bladder symptoms. So often we think that the bladder is reacting to whatever is going on at the vulvar level, and it's just trying to protect you. But in protecting you, it goes into overdrive and it really causes a lot of pain.
And so one asks, can IC cause itching and discharge after intimacy?
Can the IC itself cause discharge and itching? So I would say is the itching, absolutely. So not everything that itches is yeast. Okay. Itching can be a nerve issue, right? So nerves, muscles, these things, the stretch, sometimes it's pain, sometimes it's urgency, sometimes it's itch. And so sometimes nerve pain can actually be a nerve itch. So intimacy, which can affect the pelvic floor and the tissue and all of that, right? So there's many factors that go into itch and discharge, but it's not always infection. Sometimes it is, right? And that's why, again, it's so challenging to do webinars where now 60 people, right, all have probably something different, and everyone wants to get, their specific medical question, this doctor who's going to come on and save the day. It doesn't work that way, right? You need to find a care team. And often I find it's a pelvic floor physical therapist who works closely with a doctor, who then works closely with a mental health provider that can make all the pain go away. I want to read you. I got a text message this morning when I was in clinic. Really quickly, I got a text message from a sex therapist. She texted me while I was in clinic and said, by the way, I can't help but share the special news that the patient we both take care of is pregnant. I have no idea if she'll think to email you, so keep the news to yourself. But the first time they were able to have full intercourse with ejaculation, she became pregnant. She only found out yesterday, but I know how happy that will make you feel. And of course, I do the happy emojis with the crying. And I said, well, remind me what we did for her, because I haven't seen her in a long time. And this sex therapist said we did a hormone cream, we did physical therapy, and we did sex therapy. She says the usual. She called it the usual. It was the coolest thing. And I said, dream team combo. And she said, nothing special, because it was just the thing we do all the time with all of our, this is the normal thing for us to do. And it's just so cool, right? That is the normal thing. And that, it was anxiety reduction. She started a medication to reduce her anxiety. She worked with a physical therapist who did hands-on approach, and we healed her tissue with a hormonal support. And now she's able to do what she wants. And it's such a magical story. It's not perfect for everyone. There are many patients that it is very challenging pelvic pain cases and very frustrating. And I don't cure I'm not a miracle worker. I just genuinely care and spend time with people.
That actually reminds me, I remember a pelvic PT one time telling me a story of her previous patient, and the husband came in and he's all like, you got me pregnant. She's like, you got me pregnant. And she's like, what are we talking about here? And it's just like, but they were so excited and so thankful. But at first it was all like, you got me pregnant.
I love that. I love that.
Yeah, and I always remember that story. So that definitely reminds me of that and being able to make that type of difference.
And I want to give a shout out to our male bladder pain patients here. Y'all have pelvic floors. Your penis is just a muscle. The muscles behind your scrotum that help with ejaculation are just muscles. And muscles become dysfunctional for many reasons. The way we sit, our back issues, the muscles that surround our tissue, constipation, big prostates. There are so many things that can cause like pain for a male pelvic floor. So this dream team that we have is not just for women. So the team is always a pelvic floor physical therapist, a sex therapist, and then we work with the tissue, the muscles, the hormones, and really to try to isolate, well, where the heck is this coming from? Where are these symptoms coming from?
Yeah, here's one great question in that arena. Is it typical to lose your libido in IC? Can you get it back?
Y'all, I don't know about you, but I do not touch a hot stove ever, right? I never touch a hot stove because I don't want to burn myself. My muscles would pull it away. And so how are you going to be interested in intimacy and pleasure if you have pain all the time, right? And so this is where it's not about quantity. It's about you really sitting with yourself, not your partner, like you, and figuring out, what do you want? Right? What do you want? Do you want to find the pleasurable moments? Because it can look a lot of different ways, right? I have another story. I talked to a patient I'm a storyteller. I had a patient on Tuesday. I talk to him every 6 months. He is 89 years old. Delicious. He's 89 years old. He walks multiple miles on the beach every day with his dogs. He is like strong as ever. He's super handsome. He looks like if Joe Biden were 10 years younger. That's how he looks at 89. Like he's like a handsome guy. His wife is in her 70s and they have sex once a week. Once a week, they have sex. They don't have penetration. It's long since he's been able to get good erections. And he says to me every 6 months that I refill he's on testosterone. Every 6 months I refill his testosterone. He says, Dr. Rubin, I am so in love with my wife. I am just the luckiest man in the world. I am so happy. I'm so frustrated. She can never seem to finish her orgasm. It drives me crazy, Dr. Rubin. What can we do? Now, I take care of his wife too, and she's not bothered by it. She's perfectly happy having sex, intimacy. He orgasms. They have touch, pleasure. They use devices sometimes, and she's fine. She's not upset about her orgasm. She and I have worked together many years. And yeah, and they have joy. They have joy. They have love. They have connection. They have passion. And he is the happiest, healthiest, most wonderful. He's going to live another 10 years at least, if not more. But this is what I mean. It doesn't have to look the same way it did when you were 19, right? But the people who still have sex, the people who still have fun are the people who find the fun. They find the pleasure. They find the joy. They find the intimacy. And it's not easy to do that when you're in pain. And so sometimes it's a season. Sometimes you got to focus on the pain. And sometimes you have to find the joy outside of the genital touch, right? Sometimes you have to really go other places in order to have joy and pleasure. If it's important to you, you can't, if you're just doing it to check the box and to please the partner, it never works out well, right? It's resentful. It's mercy sex. It's duty sex. It's not fun. It's not pleasurable. And so you got to really decide for yourself what you want it to look like.
Perfect. And then we've got a few questions here. I'll kind of chime in at first and then love to get your thoughts, Dr. Rubin. So we have a lot of questions about finding a urologist like yourself. And first suggestion is going to be go to the Interstitial Cystitis Association. If you're looking for a doctor or that specializes in that, they have an entire Find a Doctor database on their website. Or you just go to Maryland and see Dr. Rachel Rubin. And then also very similarly, we have recommendations for requests for pelvic PTs. Yeah. I would suggest the American Physical Therapy Association, their section on pelvic health. They have a find a provider tool, and all of their members are listed in there. And you want a member of the American Physical Therapy Association would be an ideal standard. In my mind, what are your thoughts, Dr.
I completely agree. Myself, my colleague, I have a partner, Dr. Kloss, who I call her the bladder pain whisperer. She is just so good at bladder. She's so good at, she's been a urologist she's a couple years older than me. I do a lot of the sexual medicine, and she now does a lot of sexual medicine, but she's always been a bladder pain sort of whisperer. And so she loves it, and I think it's really, you got to find a doctor who loves managing pain. And in our practice, we have the time to do so. Whereas in a lot of urology practices, they blow you off because they have 10 minutes. So would I rather talk about kidney stones for 10 minutes where I can be a hero? Or would I rather talk to you for where I can't even scratch the surface of your 30 years of pain in a 10-minute visit? So I'm going to block and say, I don't do this. I don't treat this. It's inappropriate. It's terrible. Again, patients suffer because the medical system is broken. So you want to see doctors who do have an interest in pelvic pain. And I think all your advice is very good. I think if you want to see a sexual medicine provider, ISWSH, ISSWSH.org. There is a find a provider. It is the International Society for the Study of Women's Sexual Health. It is a wonderful, wonderful organization where we do sexual medicine. And so certainly you could try to find a provider. Now some of us do specialty clinics. I'm trying to grow this, but you come in and you get an even longer visit. It's like a 2 or 3 hour visit with a pelvic floor physical therapist and myself and my colleague, to really tackle complex cases, because the thing that you deserve most is people's brain power to just quietly focused on your story, right? And I wish I had all the money in the world to have free visits for everybody and every expert in the world in my clinic at one time. I swear, if you know any billionaires, I would love to talk to one. Because we need this. We need giant centers where we can really do this at a high level for everybody. And it's just unfortunately not possible.
A little bit at a time, right? Definitely. Here's a good question that leads into this a little bit. One wants to ask, should I see a urologist, an OBGYN, a urogyn? What do you think?
It's not easy, because again, a 10-minute visit is a 10-minute visit anywhere that you go. And so sometimes you got to see a couple people and get a couple opinions, and you have to be the gatherer of information to build your team and decide, am I going to travel for specialty care? Am I going to read the reviews a little bit extra? Am I going to see what my friend thought of this person? There's a lot of crowdsourcing. I get lots of patients who say, oh, I read all the things on Reddit that people had to say about you. You say, oh my gosh, it's a good thing I try to be nice to everybody, right? Because y'all talk. We all know y'all talk. And so this is where it's very challenging, because there's no magic potion. There's no magic wand. I certainly don't have a magic wand to make all of you all better starting today. And so it's a team effort. It's really understanding and finding someone who's going to be your team member to really tinker with what is available and what the options are. And you got to try different things, as you all know.
Perfect. And then I think where we should lead into this is a very important question. Where can they find you? Where can they find you on social? We've got that question. What's the name of your clinic?
Yeah,
they
so
want to stalk you.
We do. So good place to start is rachelrubinmd.com. So you see my name under my face here, rachelrubinmd.com. We have a nice newsletter. So if you feel interested, you can sign up for our newsletter. And I don't spam you. I try to keep it with interesting podcasts, interesting news articles, and you'll see pictures of my kids probably. Sorry about that. I'm a proud mama. So you can sign up for our newsletter. I'm pretty loud on Instagram these days. It's I do Facebook as well as Twitter. It's the same handle. It's the @ Dr. Rachel Rubin. So actually just what you see here, Dr. Rachel Rubin, and follow along. I really try to give high yield tips. I really try to promote my friends in the field, because there are some really great people doing really great work. And the more we can shout each other out, the more you can really have access to really amazing, amazing people.
Perfect. And I guess I should throw this out too. What is the contact info for Desert Harvest? That is really, it's easy. desertharvest.com. And same thing on social media, on Facebook, Instagram, all that, Twitter, all the fun stuff. We are available on there, and maybe Nick, we can pop that in the chat as well. And I don't think we can get to all these questions, but we do have a few more minutes. Dr. Rubin. Is there anything else we could hit here? A lot of these aren't very
broad. So I think
yeah.
it's, again, and I'm getting a lot of questions I see about bladder installations. I will be honest with all of you. I know bladder installations help people, but if you're doing 12, 24, 36, 82, 112 bladder installations, well, and they haven't touched you and they haven't helped you, I don't think another round is going to do it. Right now, if you have Hunner's lesions and ulcers and they see them on cystoscopy and they burn them and you feel better, I have seen miracles. I have seen incredible outcomes for that. But if bladder installations help you, then do them, right? And they might be helpful. But I think too many people are offered them over and over and over again, praying for some miracle that is not there. So what I like to say is, when something isn't working in our algorithms that we have, it's something else. There's something we're missing, either in your spine, in your vulva, in your brain, in your tissue, in your muscles. There is something that somebody is missing. Now, maybe science hasn't figured it out yet, and there's always that risk. And we still have lots more to learn. But just, again, if you keep doing the same thing over and over again and it's not leading to the results that you want, you need a different eyeball approach. And sometimes that's taking a step back. And I'll tell you, even me, I get tunnel vision. I'll have someone and I get tunnel vision on what I think is going on with them. And I pray for them to go to someone else to look at it from a different angle and say, Rubin, I think you had tunnel vision. I think it's this. Oh, it's the best when that happens. And so you have to sometimes get new eyeballs on your story. And the most important thing is, your story deserves to be told and heard, right? Your individual story matters. It really matters, and it should matter to your doctor. But the system is set up where you cannot be a human in that exam room. And it just makes no sense. You're a human with a whole life, a whole world, it just, again, it's very frustrating. And that's why I live in my own little clinic away from the world, and I do it my own way. And I have to make, it's not perfect. It certainly is not perfect, but we're just trying to survive, and we're trying to push the field forward any way that we can and validate all of you and just say, we're here, we're listening. This totally stinks to be on the edge of science and not be able to have an easy fix, an easy thing, an easy treatment that makes it all go away. And so I am sorry for what you all are going through. And I know you're all listening to me because we have had rock steady attendance this whole webinar. I don't think anybody has left, because you just are learning, you're soaking up the information, because this is survival for you. And so if we have to have, thank you for constantly learning, constantly questioning, constantly pushing for new therapies. Thank you for the ICA for allowing there to be a community, because everything is about community and having friendships and community and people who are paying attention. And so thank you to this group, because it is so, I believe that patient-led organizations are the thing that changes the whole world. It's the thing that pushes science into the right directions. It is the thing that matters the most. So do not stop, keep going.
Agreed. No bias there, just wholeheartedly. Well, I'd like to thank you, Dr. Rubin, for joining us tonight, for taking time out of your evening and your busy schedule to spend time with us, answering questions, and definitely make sure we put it here in the chat. You check out Dr. Rubin's site. Your passion and what you do for your patients and the time you spend and what you give back to them is amazing. And I just want to say thank you too, because we hear day in and day out from Desert Harvest about you. And I just want to say thank you myself. So thank you again, Lee. I will let you take it away.
Thank you so much. And I second Heather. I just want to say that was a phenomenal discussion. I know that I learned so much today from you, Dr. Rubin, and I'm guessing that our attendees did too. So thank you so much for being with us and for sharing. And Heather, thank you so much for bringing Dr. Rubin to us. This was amazing. And for Desert Harvest sponsorship of today's webinar, as well as all of IC Awareness Month, all the activities that we have going this month. So for those of you attending, if you haven't already, Please donate to the Pain to Purpose event or sign up to fundraise. Your support allows us to continue to bring you amazing programs like this one. Go to the ICA's website at ichelp.org to learn more about how you can support the ICA during IC Awareness Month and beyond. And if you have found this event to be helpful and of value, please consider joining us for future webinars and share these opportunities with your community. And then lastly, that friendly reminder to please complete the post-webinar survey that we're going to post here in the chat. So once again, thank you so much for joining us today, and have a great night.